Hi, I'm Eric Johnson from the Center for Digital Strategies, and I'm here today with Andy Gettinger. Andy Gettinger is the Chief Medical Information Officer at Dartmouth Hitchcock. He's also the Associate Dean for Clinical Informatics. And Andy's had a long involvement around the EHR world, leading EHR implementations at Dartmouth Hitchcock since the 1990s. But most relevant today, Andy's been part of a very large rollout of a new EHR at Dartmouth. And today we're going to chat a little bit about that and particularly think about some of the learnings that you might have for implementing your own EHR. How to think about what to pick, are you ready, and how to avoid some of the real pitfalls along the way. Well, Andy, you started this journey over 5 years ago, and when you start thinking about EHR and an EHR implementation, how did you go about thinking about something that's going to take years of effort, cost tens, hundreds of millions of dollars, change the work processes of lots of clinicians, just a really kind of big impact. How did you go about thinking about deciding to do that?
12 years ago, we decided as an institution that we were going to do an interim strategy of our own software development. And the purpose of that was to start to move towards an electronic health record broadly distributed so that our doctors, our nurses, our pharmacists all started using the same electronic tool. We developed it incrementally over time. So what we started 4 or 5 years ago was a reconsideration of whether the market had changed and whether the vendor offerings in EHRs were going to be sufficient to meet our needs. Now, we had a couple of requirements when we did that. We expected that the ambulatory portion of the EHR would be the same as the inpatient portion of the EHR, so that a clinician using the EHR wouldn't be disoriented between those transitions. We expected that the EHR would be used successfully by physicians and other clinicians documenting their notes in the record, by nurses doing what's called an EMAR, electronic medical administration record, and point-of-care safety things such as barcoding at the bedside. We also expected our ordering providers, mostly physicians, but also nurse practitioners and physician's assistants, to do what's called CPOE, computerized provider order entry.
Well, that's a big step. How do you know if the organization's ready for such a kind of major EHR rollout?
Some of the real advantages from EHRs come from some of the advanced features. Decision support, clues to help clinicians actually use the record. And then the derivative value of field-defined or actionable data that's entered into the computer by the clinician can actually characterize various episodes of care and can allow for quality improvement and research opportunities. And we realized as an organization that we didn't have the resources as a single, even though we're a large institution, we didn't have the resources to actually achieve that on our own. And what we started to see coming out of the National Informatics Societies, the Davies Award in particular, which is sort of like the Emmy Award for good implementations of EHRs, were institutions that were successful with vendor-produced product. So we hired some consultants who came in and got to know us. And actually, the consulting group we used we've worked with over years, so they didn't have to actually learn that much about us because we were known to them. But what they brought was an independent review of our current situation, and they did that by a series of interviews with key decision makers and then rank and file clinicians, nurses, doctors, students, house staff. How's this working? And so what they came up with was some assessments. And some of their assessments were actually daunting for us to consider. They suggested that we had great variability in our processes. They also suggested, imagine this, that we were a little resistant to change, and that our culture may not support this kind of change. And we looked at that, and we took their advice and really tried to designate this not as an information systems initiative, but as an opportunity to do clinical transformation. And that's what we titled the project, Clinical Transformation. And we actually had a dramatic amount of participation from institutional leaders, because we thought that was going to be essential for our success. And that went all the way up to the boards of trustees. And what they basically said is, we endorse your proposal, which is we're going to put in a very large enterprise system that's not only on this campus, but also spreading out to the two large communities in the Southern Community Practices, Manchester and Nashua, and try and pull everybody together on the same electronic medical record. That same platform then allows us to realize some of the efficiencies that we didn't with different versions of electronic health records. In an even bigger, broader sense, we wanted to be able to partner with our colleagues at the University of Vermont at Fletcher Allen and our colleagues in Maine at Maine Medical. And so our choice of vendor actually took into account the vendor decisions that both of those entities had chosen as well.
Yeah, well, let's talk about that vendor part, because once you've decided to step off the curb and really do something big, and of course that was a board level decision for DH, how did you go about evaluating the alternatives? There's, a half a dozen alternatives out there, and a lot of different stakeholders that have some piece of the action here in terms of decision rights over what you would implement. So how did you go about evaluating those?
I think that was actually some of the strongest work that we did as an institution. We constituted a committee of doctors and nurses, led by one of our medical directors from the community practice. Not led by me or some of my other colleagues in IS. And many of the physicians and nurses who were on the committee really hadn't had any prior engagement with us. Remember, they came from operations. So we had leaders, we had physician trustees, we had section chiefs, but then we had some just regular folks who practiced. And we hired, again, a consulting group at the outset of that to come in and sort of outline for us what the market looked like, and to hear from us what our goals were. And again, I've already mentioned one of the real important ones was this notion that we didn't want an ambulatory record and then a separate inpatient record. We wanted a continuum of care record. And as it turns out, that became a very substantial differentiating point in the marketplace. So the consultants helped us to identify, and we were aware of probably 6 vendors. We chose not to allow our own development group to compete. And in retrospect, it's interesting, had they participated, they probably would have been the second place thing as we actually looked at the market. Now that's an important point, because what it speaks to is the degree of success that we had with our own internal development, and that set in place some of the challenges that we faced when we substituted the vendor's EHR for our EHR, which was very well received at the time we made our transition. So let me go back to the consulting initiative. We told the vendors that they had to come for a week each. Now the vendors looked at us and said, we don't do that. We said, well, that's okay. We feel we need a week with you to actually understand what your systems are able to do and not able to do. And so I spoke about the clinical group, which was really a very substantial part of the decision-making group. But we also had business group, some of our materials and supply group, some of the finance folks who participated in this discussion. But really, we're talking about the prime tool for clinicians. So we wanted clinicians really to sort of be the principal drivers of the decision, which ultimately went to the trustees, as you've already mentioned. So we actually bonded as a group over time. So every other week, for a week, just getting doctors and nurses to have that time was a challenge, and the institution supported it. And we would be there, and we ordered the visits by the least likely to succeed to the two most likely to succeed. And then we instituted a process similar to Survivor. So the first two vendors came, and quite frankly, we were a little disappointed, but then we had two on the island. And when the third one came, at the end of the week, we voted one of them off the island. And we followed that all the way through until we had two different vendors. We then went into the second phase of the selection, which is really important when you're buying an EHR, is the vendors have very, very slick presentations with lots of bells and whistles, and they're expert at making their systems work. That's very different from actually seeing real clinicians using the system and going to places and sort of seeing how it actually functions in real life. So we did site visits, and we split the site visits between sites that the vendor chose. We gave each of the vendors a site for them to choose, and then knowing folks in the industry the way we do, we chose some sites, figuring that there might be a little bit of a different story and perhaps a little bit of a more balanced presentation. And those site visits, again, which had about 25 or 30 people participating, really were very instrumental in the clinical group's recommendation. In fact, at the end of the site visits, the clinical group wanted to decertify the second place vendor because they really couldn't find a place where the software was being used the way we articulated our vision. And there were all kinds of excuses. You went the wrong day, you went to the wrong place. We said, whoa, you picked the place. In fact, we gave the second place vendor a third chance. And we said, one more chance, your best shot. And we ended up going to a place, and the team that went on that visit, I didn't go on that particular one, was so disillusioned with what they saw that they came back, and it was a very easy consensus. You know, in medicine, you never get a consensus. This was 100%. Everybody said, we've got to do this, which was challenging for the organization because the partner we chose is a very successful partner in the marketplace and a very costly alternative compared to some of the other alternatives. But we felt that, again, this was going to be the house that we live in, day out. We wanted it to be a functional house and a comfortable house and a house that we could grow in. And I think that's what we came up with.
You really hear, and it's just so good to hear this, Andy, a couple key points, just the due diligence of really kicking the tires multiple times. But more importantly, all these stakeholders, the real users, not something driven by IT, but really the users being deeply, deeply involved in the decision process.